بله بله افرادی که جوین شدن
Hello everyone, welcome to this session from the international section of the Tehran University of Medical Sciences. I think it is the first session about treatment in neurology, and we begin with a topic of IV thrombolytic in acute stroke. Our respected speaker is Dr. Nourian. He graduated from Tehran University of Medical Science in 2006. He continued his education in research section of Emory University in Atlanta. He got his neurology specialty from Emory University, and he got his fellowship in vascular neurology from UCLA in 2013. He is a very professional colleague of us. It is a great honor for my Iranian with these intelligent colleagues aboard. Please, Dr. Nourian, begin your lecture about acute treatment in stroke.
Hi, everybody. Thank you, Dr. Ghani, for wonderful introduction. With scholars and professors like Dr. Ghani, Dr. Nafisi, and my previous professors like Dr. Sarayan. I'm sure there is no reason to give theoretical aspects of acute stroke care, but I thought this would be a great opportunity to go over the practical things that we do on a daily basis and how we can compare it to our practice in local communities in Iran and elsewhere. I'd like to thank Dr. Yaghmai for facilitating this from the beginning. It's my honor to talk to you guys. I'm a vascular neurologist, as Dr. Ghani mentioned. I don't have an outpatient practice. I work as a neurohospitalist and a stroke physician. Basically, I manage all the neurologic presentations and complications in hospital setting. I also do administration work and manage two stroke centers in Orange County, California, Irvine Medical Center and Anaheim Medical Center. I used to be a visiting faculty at the UCLA, but for family reasons, I haven't been able to do that. But I'm closely following their work and my interest for future collaboration, and I'd like to help in any way I can is to design stroke centers of care and systems of care, pre-hospital evaluation of patients to improve door needle times ultimately. So with no further delay, I start my presentation. Let me make sure I'm sharing my screen. Can you guys see that?
Yes.
Okay, perfect. So these are the two hospitals on the right upper and left upper that I work with, and the center is the UCLA that I worked on until a few years ago. This is the outline of my presentation today. We'll have an introduction for sort of bringing everybody up to date of what is TPA, thrombolytics, TNK, how do we do patient selection, inclusion and exclusion criteria. We'll focus a little bit more on special clinical situations based on the original selection criteria, inclusion and exclusion, how things have evolved to where the everyday practice is now. We'll go over safety checklists that are routinely done and outcomes. We touch base a little bit about complications and management. We'll talk about extended time windows using advanced imaging, connected plays, and then stroke systems of care, telestroke, and the future. As you are all aware, the mainstay of acute ischemic stroke is based on timely recanalization of the occluded blood vessel, and successful recanalization has been strongly associated with better clinical outcomes. Alteplase or TPA is a recombinant tissue plasminogen activator, which binds to fibrin in a thrombus, and it converts the entrapped plasminogen to plasmin, which ultimately breaks the clot. The usual pathways when the patient gets to the emergency department, they get a stat brain imaging, usually a non-con CT, and then the decision is made to proceed based on the timing and inclusion exclusion criteria to proceed with thrombolytics. Depending on the delay in different centers, they include CTA and perfusion in a rapid sequence versus consider the patient first for TPA and then give the TPA or thrombolytic and then take the patient back to do further imaging, not to delay the thrombolytics, which we'll talk about all. The original study, which was done in the mid-90s, basically the NINDS trial, had a inclusion and certain inclusion and exclusion criteria. For the longest time, they have been the main inclusion and exclusion criteria. As you see on the left side, basically any patient with sudden onset neurologic change that could be attributed to an ischemic etiology within the first 3 hours initially, and then it was expanded to 4.5 hours for patients who are older than 18 years old. With these contraindications, severe head trauma, symptoms suggestive of subarachnoid hemorrhage, any sort of bleeding, recent surgery, intracranial neoplasm, and infected endocarditis. I don't go over all of that, but this was the main exclusion criteria that actually even in the beginning of my practice and residency, I noted that patients with just blood pressure a little bit above the usual range, they were excluded. Also, like any sort of bleeding, urinary or gastrointestinal or other source, there were kind of strict contraindications not to consider thrombolytics. As time went on, a lot of these were more relaxed, and people realized that the risk of bleeding is less than what we usually would expect. So things like high NIHSS strokes, if they had any sort of surgery within the last 2 weeks in certain conditions and 3 weeks, these were less kind of considered as contraindications. And what became more prevalent was having a discussion with other specialists and also patients and families and discuss with them. Also, the initial presentation and the symptoms that were involved also came more into the picture to see how disabling the symptoms are and what are the risk versus benefits of offering this medication, and what is the potential outcome versus what would be the complication from, let's say, a recent surgery or recent procedure. And so we as you see here on the left side is the original one, and then as time went on in up-to-date other publications, they removed some of those, which brought us to the 2018 guidelines of thrombolytic therapy by AHA-ASA, which I'll go over some of them to kind of discuss more about what is important. I also want to touch base about, before I start this section, about the symptoms. As you are aware, we are using the NIHSS National Institute of Health stroke scale from 0 to 44. Because this was used in the original trial, and also it has been used as a validated tool to compare severity of strokes. This is commonly used as a time zero evaluation and decide what we want to do. But it's important to know that any score on NIHSS, they don't like one scoring aphasia is not the same as one scoring dysarthria, for example, or numbness. And so it's very important to see if a patient with NIHSS of 2, is it just because of facial droop and dysarthria versus an NIHSS of 2 of field cut? Because if somebody has homonymous hemianopia and gets an NIHSS of 2, that means that he or she cannot drive. But an NIHSS of 2 of just for dysarthria or numbness, even without intervention, that will usually get better. So especially in instances that we have a sort of relative contraindication, it's important to consider those in our decision making. In my own practice, I usually give more weight to field cut. If we have a language deficit, having more weight than if we have dysarthria, for example, because there's more cognitive aspect of injury. And then motor weakness versus just numbness, I would give more weight because it can potentially be more disabling to the patient. Ultimately, for posterior circulation strokes, we don't have good NIHSS correlation. I usually see whether a patient can walk or can basically communicate walking or seeing. These are the main functions that we should consider when we are talking about risk versus benefits in each of the scenarios that come to us. So going over these relative and absolute contraindications with the new updates based on the previous studies, blood glucose is one of them. Before, I remember days that we would, any patient with less than blood glucose of less than 50 or more than 400 would be automatically excluded from any sort of intervention. The way we do right now is we try to fix, especially with low blood sugar. We immediately try to fix and see, and usually even by paramedics or EMS or ambulance before coming to the hospital, that part has been treated, and we can see after treatment whether the patients have improved symptoms or not, and then it's okay to consider thrombolytics if we don't see major improvements and we still see disabling symptoms. Coagulopathy used to be a strict INR less than 1.7, which or using new oral anticoagulants. These are still I'm sorry, before, even regardless of INR, people were more cautious about using thrombolytics in this group of patients. But now we are more kind of liberal in taking care of these stroke patients, especially in the extended time, the 3 to 4.5 hours. Before, we used to say any patient, as we see in the previous slide, in the middle screen lower, any sort of anticoagulant used, regardless of INR, was a contraindication. But now, in 3 to 4.5 hour time window, if we see a devastating presentation like hemiplegia or aphasia, then that can be considered. Dural puncture, arterial puncture, these used to be absolute contraindication, but now it can be considered. Same with arterial puncture. Another example in kind of these categories, we used to say no blood draw after TPA, so patients wouldn't get any blood draw. But now we know that patients who get thrombolytics, we transferred them or do thrombectomy right there, which is basically an arterial puncture, and we haven't seen much of complications as a result. We can use more conservative measures in taking care of the puncture site afterwards. Same with major trauma. If there is no direct head trauma, that can be considered, of course, after discussion with trauma or surgery, or depending on what the situation was, we can consider that. Any major surgery, this actually is one of the more relaxed, contraindications. If patient has had ortho surgery or uh, uh, gynecologic surgery, or we always, let's say 2 weeks, 3 weeks, we always reach out to the on-call surgeon immediately and discuss with them. And a lot of times they say, save the brain, we deal with it later. This is more kind of relaxed um, in more kind of disabling scenarios. I briefly talked about the 3 to 4.5 hour window. We used to have strict contraindications as far as age, current risk of diabetes and prior strokes, severe strokes, and now they're more kind of relaxed. I'll talk about the wake-up strokes later. Pre-existing disabilities by itself, it's not a contraindication, but we used to kind of rule out all these patients or patients who have had malignancies with poor outcome. But now, it all depends on even if we have like a few years or few months left, whether the stroke is causing, disability in that short time period that's left for the patient, and we can consider those. Early improvement of the symptoms. Again, if the patient has had improvement, but we still deal with a disabling symptom, or if we have evidence of, let's say, patient is improved, but we have a clot that we just saw in the CTA, we should usually go ahead and still consider thrombolytics. Seizure at onset, if we see that there is a seizure, we should remember that 10% of strokes can present with seizures. And if the improvement in that time range is not back to baseline, and we still see major disabilities, especially if we have additional imaging that can help us, if there is any clot that we see, or if there is any perfusion deficit in cases that we have perfusion availability, or if certain centers they have hyperacute MRI, then we could consider those. Menstruation is usually safe when we discuss with OBGYN. Dissections, extracranial cervical dissections. It is now we know that the patients who get that, who have got that, and then they have been included in case series, it is reasonably accepted to consider that. For intracranial dissections, it's a little bit more risky, and still we don't have enough evidence. Unruptured, but the thing is, most of these cases, we know about them later. We might get a non-con CT, and we proceed with thrombolytics, and most of the time, I haven't seen any major complication or any complication from that kind of intervention. For intracranial aneurysms, it used to be absolute contraindication. Now for smaller aneurysms, we can consider that. For patients with, again, vascular malformations, it is not well established. Again, it's all about, this I would, if I see it's large, if I see there's, if I have previous MRI on the imaging and I see the GRE changes, I would probably hold off. Also, a history of ICH, intracranial hemorrhage. In patients, like if they had ICH more than like a year ago or more than that, again, that's something that used to be an absolute contraindication, but now we can consider patients who have deep hemorrhages history, if it was in the setting of hypertension. That's different than if we have a superficial cortical, larger size hemorrhage, which brings down to cerebral microbleeds, like in amyloid angiopathy, now we have studies that we know it's more of a how much is the hemorrhage burden, the number of these GRE microbleeds. If you're less than 10, then you are more kind of towards to consider the discussion versus if it's all over the place. We have more cortical or larger ones. Or if I see a patient who has had multiple MRIs, there is progression. That means that there is higher risk associated with these microbleeds. Glycoprotein 2B3A inhibitors, it's not well established. It's not also that common with the IV forms. With Plavix, there is certainly no concern, just like aspirin history or dual antiplatelet therapy. For neoplasms, intracranial neoplasms, I would still be very careful, especially when we have infiltrative process, enhancing lesions. Those are more prone to hemorrhage. But if you have an extra axial intracranial neoplasm, meningioma, those usually tend to do better or safe with thrombolytics. Again, size is important, and basically the whole presentation. If somebody has a large, extra axial even lesion coming in with just numbness, I wouldn't touch it. If it's again hemiplegia or like major aphasia, then I would consider treating that. For patients with acute MI, with concurrent acute ischemic stroke and MI, treatment with IV TPA with appropriate dose for ischemia, followed by PCA and stenting is reasonable. For patients with recent ischemic stroke and recent MI in the past 3 months, this used to be a kind of contraindication, but now we know that for end-STEMI cases, it is reasonable. For even STEMI cases with right or inferior myocardial involvement, it is reasonable. And then for patients with left main, that may be reasonable. So that kind of shows that it's more kind of to be more on the cautious side. Same with pericarditis. If the patients will have severe disability, the discussion with cardiology will be important to discuss on these cases. If there is a left atrial ventricular thrombus, this used to be a definite no, but now it's more relaxed, and basically with patients who have, we talked about it, if it's like mild disability, it's uncertain, and I personally wouldn't do it. Same with myxomas. They're not that often, but it can potentially be considered. I think from mechanistic standpoint, probably not going to be as helpful as if it was a RBC rich thrombus, which the TPA or TNK could help. Endocarditis is one of those that if you have high suspicion, it's high risk. We have had cases that patient had significant disability, and a stat angio would be done to rule out myocardic aneurysms. And in those cases, usually, if we see a large vessel occlusion, it's just better to proceed with that versus accepting the risk. So those are kind of still high risk that we don't have enough patients to include in trials and have study the safety of. Patients who just had a cardiac or cerebral angiography, again, it is reasonable to consider those. With systemic malignancy, if there is, we have an acceptable prognosis, life expectancy, and we don't have other coagulation abnormalities, it is reasonable to consider. Pregnant patients, in the first 3 months, usually the decision is not to, but the second and third trimester, it is more kind of relaxed, especially if it is associated with significant disability. Towards the end, when there is concern about uterine rupture, we have a close, a discussion with OBGYN and proceed. For optimal patients who present with monocular vision loss, we have started to consider those after an initial quick evaluation by fundoscopic exam. We recently started to use fundus camera in our emergency departments that they get a quick scan of the image that they put like the device on the eye and then it gets a quick picture. It's sent by text to on-call ophthalmology. They review that and then they give a quick okay, and then we consider thrombolytic therapy for central retinal arterial branch retinal arterial occlusion because it can potentially be a disabling stroke or symptom or stroke equivalent. And more rare cases with sickle cell it can be considered if we see hyperdense MCA sign, especially in that early on, it should be considered. And the stroke mimics, a lot of times when they present upfront, we don't know there are stroke mimics, so that definitely should be considered. And I actually wouldn't worry much about non-stroke, basically the stroke mimic presentations, because the usual bleeding risk that we quote is not for patients that have mimics. It mostly happens in patients who have actually ischemic stroke. So there is usually a 10% false administration of thrombolytics in different centers, which is acceptable. Patients who come in with migraine or conversion or other etiologies. Ischemic stroke within 3 months. It is still one of my more strict, basically contraindications. Severe head trauma, again, in the last 3 months, and the acute head trauma, post-traumatic infarction, but those are still considered as higher risk for me. Again, intracranial, intraspinal surgery within 3 months, it is highly associated with worse outcomes. History of intracranial hemorrhage. Usually this is more even after this guideline in our daily practice. If somebody had ICH, for example, 5 years ago, 10 years ago, and we have workup suggesting it was a hypertensive, thalamic hemorrhage, that can be considered. But more recent hemorrhages, subarachnoid hemorrhage, especially the ones that it's not secured, we don't do that. Even more aggressive, a stroke neurologist will not consider that. GI malignancy, GI bleed, with a structural GI malignancy, recent bleeding, it is high risk and could be harmful because this could lead to a devastated, bleeding, GI bleeding that could be a not disability issue, but more of a mortality issue in such such state after thrombolytics. Platelet numbers, it's still an absolute contraindication, and we talked about new oral anticoagulants later. Lower molecular weight heparin for prophylaxis. For prophylaxis, it is okay to use, but a full dose therapeutic heparin is contraindicated. We will talk about thrombin inhibitors and factor Xa inhibitors in a separate slide, but it used to be patients who are not on any are on any of those are automatically contraindicated for now, if a patient has not been on those beyond 48 hours and coagulation numbers are okay, on a case-to-case basis, we consider that. Um, and these are about integrating or apixaban use. It should not be administered with TPA. There are some studies that are going, but it is still within the research, uh, realm. IV aspirin in some countries like China and Japan, it is considered, but not for thrombolytics. We talked about endocarditis and aortic dissection is harmful and should not be administered. We talked about intraaxial, intracranial um, uh, neoplasms, which is potentially harmful. So basically, I talked about these, but basically, when a patient comes in with no known, bleeding risk, surgery, blood thinner, no recent trauma, one luxury we have in our system, we usually cover 15 hospitals when we do telestroke call. We have the medical record of all these Kaiser Permanente hospital in our system, even when they are in the facility, the rehab facility that they are in, their daily notes are in the system, so we can have access and quickly check the last medication list. So we don't waste time for waiting for PTT. We just look at the blood glucose and then we order the TNK. Same with like if there is no strong history for cardiac event, we don't wait for EKG troponins to come back. And same with basically if we don't have a known history of thrombocytopenia or coagulation problems, we don't routinely wait for this in the interest of time to thrombolytic therapy. To continue the special situations, as I said, when new oral anticoagulants with dabigatran first and then later rivaroxaban and Eliquis or apixaban came to the picture, it was a strict no-no. Then we had the criteria based on the last use within the last 48 hours or longer, and then depending on GFR, renal function, and also the uh, thrombin time and anti-10A levels. But all those usually depending on the center, people were more aggressive or not. But more recently, we have started to use for stroke community reversal of Pradaxa or dabigatran by Praxmine and then administered TPA immediately. And more recently, even tenecteplase in those scenarios. There are even more studies coming. I have personally not done this, but there are more studies that are coming and say, the use of NOACs or DOACs are not associated with symptomatic hemorrhage as we thought. In this study in particular, which was published in JAMA, they went over more than 800 patients who were on DOAC even within 48 hours and were given basically thrombolytics. And all these patients, the INR and PTT were normal. The risk of hemorrhage in this population was 2.5%, which is actually very low compared to in this study, they had like 30,000 control patients in the database. So it wasn't like a randomized clinical trial. It was basically a combination of basically different population case series review. So they realized that recent use of DOACs within 48 hours, if the coagulation studies, INR and PTT, were normal, was considered safe. If the patient was on Pradaxa based or dabigatran, they still would consider using reversal with either rituximab or Praxmine, and they this is like obviously a single study and it was published, but it hasn't come to the practice guidelines. But I think as these studies are coming, I think people are more comfortable with using, uh, thrombolytics in these patients. Um, like these numbers are much better than warfarin or Coumadin. So basically, this is more of a kind of a basic but important slide on what are the safety checklists taking care of these patients for some of our more junior practitioners. Basically the most important thing that is often most inaccurate data when we have when you're consulted is the last known well time. When was the time patient was completely seen? It is often mistaken by emergency medical services or ambulance staff with time the symptom was noticed. This is actually a very common problem that it's important to go back and see when the stroke semiology does not happen in front of our eyes. Then it's also important to know the baseline, previous level of functioning, goals of care, past medical history, medication list, when was it taken last time, and a brief neurologic exam. What we usually encourage our emergency medical doctors is not to spend all the time to go over the full NIHSS exam and waste time. It's just a quick evaluation. Oftentimes it's done by EMS either before presentation, and not spending too much time on the pre-stroke activation, and let us neurology take over and do more kind of digging. Then interpretation of imaging, contraindications, obviously vital signs are important. I forgot to mention the blood pressure, even if it's like very high, we usually try to bring it, let's say if it's 230 over 120. We usually right at presentation we give a dose of labetalol and go for a CT. If there is no hemorrhage, when the patient comes back, we order TNK or TPA, and at the same time a calcium channel blocker drip, like clevidipine drip or nicardipine drip, to quickly bring down to less than 185 over 110, and then at that point we give the thrombolytics and maintain the patient on drip. This is different than the previous, practice that I remember in residency. Patients' blood pressure was like 190 over 100, 110. That was just the contraindication. And dose and weight of the patient is very important. Get the weight right at the time before ordering, and then pharmacy checklist, and accurate administration of TPA, and then right IV access, and then obviously post-TPA monitoring. Complications, the intracranial hemorrhage, everybody knows. Different numbers quoted, anywhere from 1 to 3% up to 7%. In our centers, it's usually less than 1%, with obviously access to medical records, all the quality checklists. But if somebody develops hemorrhage, we should immediately discontinue TPA while it's being infused. If we realize the worsening, stat CT head, type and cross match, PT-PTT weighted numbers and fibrinogen level, neurosurgery and hematology consult, mainly neurosurgery. If later we see that it's a severe hemorrhage, but I wouldn't waste time on those consults before proceeding with reversing by giving cryoprecipitate, anticholinergic agents, and in cases that patients were on warfarin, further management. Angioedema, which is less talked about, but it's important. It's more common in patients taking exhibitors, and for some reason, in patients who have frontal or insular cortices, it has been shown to be more common. It's overall not as common. I'm sure you also have noted that. Interestingly, it's typically mild, transient, and it's contralateral to the ischemic side. The usual management is ABC and intubation if needed, and a series of IV methylprednisone, 125 milligram IV, and diphenhydramine, Benadryl 50 milligram, and then famotidine. If it continues to worsen, then we consider epi right away, and in refractory cases, these are the newer treatments. I personally have not used them at all, so I don't have that much practical knowledge about it. So the outcomes, it's very time sensitive. For every 15 minutes, there's a 3 to 4% increase in odds ratio of walking independently and the possibility of discharging home. The number needed to treat to achieve independence at 3 months for TPA. For the first hour of administration, it's 3. For 3 hours, it's 8, and around 14 at 4.5 hours. These benefits are there even after correcting for age and stroke severity. The number needed to harm is 18 for symptomatic and 44 for fatal hemorrhage. Thrombolytics and imaging, it's not widely available even in the US, but in more academic centers, and we have MRI brain stat. Actually, in some centers, like where I used to be at UCLA, Mass General, and some other centers, they don't even do stat CT. They just go straight to MRI. So that way we can use for patients who are wake up or last known dwell time is unknown. We can get a stat MRI brain, and depending on the DWI flare mismatch, if we see evidence of DWI like on the left side and we don't see any flare changes, that suggests that based on the tissue characteristics, we are within kind of 3-4 hours range of giving TPA. And on the right side, these patients, I would not consider that because we already have flare changes, and that shows that the time of a stroke is beyond 4 or 5 hours. There are in previous studies like EPIPET, CAS4, and Extent, I believe, they used MR perfusion for TPA administration, or in some centers even CT perfusion if the volume mismatch is more than 1.2, mismatch volume more than 20 ml, and implant volume is less than anywhere between 70 to 100 ml based on the studies. But this is not like commonly used, but I just put it as a guideline or as a kind of mentioning that in some studies they have considered those, but it is usually not used in everyday practice, and the more kind of based on DWI and flare is more accepted. More recently, there is a trend to switch from TPA to tenecteplase, which is basically a recombinant TPA with 3 amino acid substitutions, making it more fibrin specific, more duration of action, and because it's more specific, the risk of hemorrhage, systemic hemorrhage, is less. Other positive things about it is it's a single dose administration in less than a minute, usually seconds. Doesn't need any infusion, especially for mixing. It makes it easier, and also administration. For patients who need transfer, what's commonly used as drip and ship, for TPA, that the patient is getting TPA in a local hospital and is being transferred for thrombectomy. It doesn't need nursing to be on board for transfer because they don't need to check the drip and all that. It's just a one-time shot and then drip. So, I'm sorry, shot and transfer, basically. No drip and ship. So it's easier. It has good efficacy and safety in original trials at 0.25 mg per kg. First, it has been shown to be non-inferior to TPA, and then later we realized that the rate of revascularization very early on in large vessel occlusions is more than TPA. So it's becoming more and more used in our centers. We have been using it more than a year now instead of TPA. But one thing is for extended window based on MRI and also pediatric stroke cases is not approved, and we still use TPA in these cases. Now, after this, I wanted to kind of touch base a little bit on the development of stroke systems of care after the TPA was introduced more than almost a quarter of decade, a century. This is like a continuum of care in stroke, starting from community to educate about the TPA and the timing of stroke, which is basically not even in the most advanced communities. Still, they don't consider stroke as urgent or emergent as heart attack. I'm sure you have seen patients who go and take a nap and things hoping for things to get better. So the design of systems of care really should start from the community, then to emergency medical services, education, and then to design of the emergency department, which I'm going to focus on those two. And then, the rest of the continuum inpatient and discharge coordinations and back to the community and how to break this cycle so we have less strokes. But that's a different subject. As my mentor at UCLA calculated in a kind of an estimate, Dr. Saver, in a left MCA or right MCA stroke, every minute almost like 2 million brain cells die. That kind of equates to 14 miles of axons for almost like 25 to 30 kilometers. So the time is very important in the more severe cases, or even less, the numbers are different, but still time is important. So people in the emergency pre-hospital, in the emergency department, everyone needs to know this is like super urgent. Usually we don't see nurses and staff to consider this as someone who has like a heart attack or like aortic dissection. Like we will take time to register patient, get vital signs, but those continue. The focus continues to change that mentality. Then neurologist role in this, since TPA came to the picture, we realized that in the U.S. There is a lack of enough neurology coverage. So people started to think about alternative ways using telestroke. When the advanced cell phone came to the picture, iPhone, there were studies that were done. This was done by my co-resident for the first time at Emory and Grady Hospital, how to use remote assessment of stroke by iPhone. This was a kind of a validation study to see it's reliable. And then at the same time, we had more telestroke using computers, basically kind of like remote evaluation as a way to evaluate the patient, to leverage care for small hospitals with limited neurology coverage and standards of care across the network or state, and to basically increase the rate of TPA administration, manage the more complex cases. So this is my setup actually. As you see on the left side, you have patient's chart, you have the imaging in front of you, and then the same camera we are using to communicate, to see the patient remotely. We cover 15 hospitals. We have 24/7 coverage by telemedicine. Even in our local hospitals in the big cities, we use telemedicine because there is one person who is sitting, and basically as soon as the patient hits the emergency, we get notified, and then we evaluate the patient to decrease the time to treatment. This was after the TPA was introduced. The door needle time came as a metric to monitor quality of care. And these were the times originally introduced. Time zero is when the patient gets to the department till they get TPA, which was initially 60 minutes. And this is still one of the metrics that's used throughout the US and internationally. But more recently, the focus has been to shorter time windows, 45 and 30 minutes. So our goals right now is to have a door to needle time of 30 minutes. Basically, as you see, to reach that goal, you need a door to physician time from the patient, time the patient gets to the emergency to have less than 2.5 minutes, to a stroke team activation less than 5 minutes, to CT less than 15 minutes, and to interpretation by 25 minutes, and then door to needle time 30 minutes. This is like still very hard to achieve, but everybody's kind of going to that direction. The things that help are having a pre-notification to the hospital from ambulance or EMS. So ED staff, triage, they're aware. We really focus on educating our nurses in the front to have a very limited, question. What's the last known real time symptoms that are involved, and then basically activate post-stroke. Having the weight measured right then, blood sugar, usually we have them before, but if not at the time. And then at that time, let's say that we are 5 minutes into the presentation. The stroke team, for example, me, is notified. And then based on that history, thrombolytic is ordered, and the patient is now in the CAT scan. The pharmacy is making it. There are times we are working actually on having the MD, emergency medicine, or the nurse to mix the medication in the CT suite to decrease some time. And then when the patient is back from CT, I'm available on telestroke cart. Sometimes the family is present before we see the patient. So when it's pre-ordered, we start to talk about the risk versus benefits. And by the time the patient gets there, you recheck the blood pressure to make sure it's stable, and then quick exam to look for disabling symptoms, aphasia, drift, motor exam, great vision testing, and you see any of those, you start to talk about disability associated with this, and then you go for the TPA or TNK, and then after that you continue to do the rest of the exam while the shot is in or the bolus is in, to have the baseline. This is to basically to reach that 30 minutes. There are centers that like at UCLA, we as fellows and residents used to mix the TPA in the MR suite, so they were like stack of TPA boxes there. So we would open it and then mix it right then and then give it. And then for MRI, it is important not to do the full sequence. Just get the DWI, GRE, and flare. So that way we reduce the time. In those centers, you get the patient, get the DWI, GRE, and flare, bring the patient out, give the medication, get the patient back, and they do the rest, because in some of those academic centers, they use MR perfusion, arterial spin labeling, even black wall imaging these days. So you don't want to waste, even in vessel imaging, if possible, it's better not to go for the full CTA perfusion studies before giving the thrombolytics. What I've seen personally is when you give that soon, the TNK or TPA, even a lot of large vessel occlusions, they get dissolved, and then they don't need intervention after this, especially when the center is not thrombectomy center. It's gonna affect the outcome major, because there's no imagine we have to give TNK and then transfer the patient. That's gonna be another half an hour by the time they get to the groin and do the revascularization. If we can give the medication quickly, that's going to affect the outcome. So another interest of mine after we started to have wearable devices was to implement use of those in stroke care. And the first device that came in 2013 was Google Glass, which is basically a wearable device that you can put and it's connected to your phone, and you can actually see the patient through like glass, and then remotely your colleague can also see the patient. So the idea was the evaluation of the patient can be initiated at the scene, home or where the ambulance arrives, and the paramedics can have those devices. And while they are evaluating the patient, you can see and you can talk. There's a two-way communication. It's hands-free, so the paramedic, you don't interfere with their stabilizing the patient. They don't need to hold the phone or carrying the computer on wheels. You can get the first-hand information at the scene, establish last known real time immediately, and then while they're transferring the patient to the hospital, you can continue evaluating before you keep the door. And there is also real-time communication between remote telestroke neurologist and paramedic, or even when the patient gets to the hospital, the emergency medicine physician or the nurse. This is one example that the Google Glass was basically, after it was produced, we acquired one of the first ones, and then you see on the left side one of the UCLA fellows is wearing that, and then remotely that's what I would see on my computer. This can be done in ambulance or at the scene, and then basically we did the first study, I believe even in the world, that to use the wearable technology to remote evaluation of acute stroke, to basically facilitate the evaluation to even before door. We are talking about door middle time, but this is kind of before even patient gets to the door. Now they're even pushing it further. I'm sure you might have heard about this, to use mobile stroke units, which was first actually developed in Europe, in Germany, and then now it's more widespread. Other centers are acquiring it. This is the picture that UCLA has it, to basically have a CT on the ambulance. So when the local ambulance companies they get a call, they quickly evaluate for whether this could be a stroke or not, and then the mobile stroke unit goes along with the ambulance to the scene. And the first ambulance staff, the general ambulance, quickly evaluate the patient, make sure it's not something else, and then they transfer the care to mobile stroke unit. Patient goes to the scanner on board, and then they have a quick CT. At the time, you can start the telestroke evaluation by the cameras on the ambulance, or with the wearable technology in the future, you can use that. And then you can decide, to give the TPA or TNK for ischemic stroke, or for hemorrhages, give the blood pressure medication, calcium channel blockers, or recently there are reversal agents to take care of the hemorrhagic strokes, and then transfer the patient to like comprehensive stroke center to do thrombectomy if it's needed. So the more advanced ambulances, they also have CT angio on board. And I actually heard that they're actually trying to put MRI on one of these ambulances in I think South Carolina in the US. So it's like they're very expensive, honestly. And in cities like Tehran and Los Angeles, the traffic is so much that these cannot go like wide distances. They're usually in a 10-kilometer radius, and this is actually just on research base. But in rural areas that they don't have access, this could be used. So there's a lot of research and clinical trials on these. They were very expensive, but I think in In the US, because of the patents, you know, they're even more expensive, but than the if you want to put them together. But if there is a somehow, you know, with technology, this can be done. I think in other countries it can be cheaper, and it can really revolutionize the stroke care. As we discussed, in these situations, you can get accurate history, last known well time directly from the family. You have improved communication, faster CT, closer monitoring from the get-go, stabilize the patient, more direct communication, um, and you have basically, you can give the thrombolytics pre-hospital, and then you can transfer to appropriate level of care. With that, I hold here to you know, have further discussion and answer any questions or opinions, and you know, basically anything, you know, I can learn from you guys.
Thank you, Dr. Nourian. Do you have my sound? Do you hear
Yes.
me?
Yes.
Yes. Thank you so much. I enjoyed so much from your lecture, and to be honest, I benefited so much. I learned new topics about especially the indication of TPA. We asked our colleagues to send their questions on chat box, but as I see, we don't have any question. So let me ask my questions. Dear Dr. Nourian, sometimes we have, this case I say that there are real cases that sometimes we discuss with our residents. For example, recently we had a patient with the right side hemiparesis. But in recent days, he had frequent TIA. Frequently, he suffered from a right side hemiparesis, which recovered completely.
Mm-hmm.
But in the day he came to emergency, he had a right paresis 2 hours later. 2 hours before he come to emergency, and we had a discussion. Would we consider TIA as a stroke? Because as you know, sometimes when we performed MRI, we see that many of the TIAs have restriction in the WI. So
Exactly.
really they are a stroke, not a TIA. Do you give thrombolytic to the patient with a neurological deficit who had frequent TIAs the day before their deficit?
I completely agree with you. In fact, the definition of TIA as we have from the first definitions in the 1990s, and then later when we started to use MRI, it has changed. You know, as you mentioned, 30% of patients who present with TIA, when you do MRI, you see strokes, and these are 1.5 Tesla MRI. So when you do when you dig more, you find more. Like if you do more, 7 Tesla, you see more findings. So in fact, the naming of these from TIA versus a stroke, it's changing to acute cerebrovascular syndrome to kind of include all of them together. But on the other hand, the original studies, when they're designed, we only had CTs. It comes down to like how much information you have, and then the trials that we had before. In those trials, what was the standard of care for diagnosis? For example, microbleeds. In the original studies, those patients, probably some of them had microbleeds on the CAT, on the GRE. We did GRE MRI for them. but when we did CAT scan and we gave TPA, we didn't know about that information. So still, standard of care for these patients is to proceed if from history standpoint. There is clear resolution of symptoms. Still, it is considered reasonable to try that. I personally, I have some concern about that. When I talk to patients, if a patient says, for example, I had it for only 10 minutes or like 20 minutes, I have more kind of like less concern to proceed with thrombolytics versus if they said I had the symptoms for like 5 hours or 6 hours and it resolved. I'm actually very nervous. Part of it could be because when I did my fellowship, we had MRIs and we see that these patients had when they came in with TIAs before, we see that they had, even within 2 hours of the symptoms, they had a lesion that was flare positive already. So the imaging timing and the tissue physiology timing estimate did not match with the timing that the patient reports. So in those, it's like a double-edged sword. Like you have more information versus you have less information, but you want to help. So I personally, we have like only CT, and then we make our decision based on the CT. If the current symptoms are disabling, and then if we had, let's say in ideal scenario, less disabling symptom, less duration, earlier, and complete resolution, I consider it. But if the patient says, I had like right hemiplegia for 5 hours, then it got better, but still I had some numbness, or I wasn't like completely back to normal, that I would not consider. As you said, we have TPA lawyers here now in the US. If you give TPA, you have complications, they sue you. If you don't give TPA, they sue you. But the important documentation is very important, and the decision making. I think I usually, if I have a feel that based on these findings, I'm going to help that patient. If it's severe presentation, I would, if I have a good scenario, I would go with the riskier approach. But if I have any of those that I mentioned, I document that there is concern for this, and this in this time window. If I can get a stat MRI, I do it in those cases. But if I don't have it, then rule number one in medicine is no harm. So I would stick to that.
Good. Professor Nafisi, as me, thanks you for your nice lecture, and he asked you, what is your recommendation for patient with mild symptom and NIHS less than 5?
So it depends on what those NIHSS items are. If they are for aphasia, even an NIHSS of 1, let's say for a university professor or a physician or public speaker or like teacher, and I would consider it as a disabling symptom. If we have numbness for someone who is I mean, for someone who is like a worker or like doing like manual job, and if it's just numbness, I wouldn't use it. But for an artist, maybe they have like significant numbness that's causing, for example, sensory drift or sensory ataxia, I would consider it. So it really depends on those NIHSS items. If a patient comes to me and only has NIHSS of 2 for numbness, or dysarthria, or just facial droop, I basically tell them, look, if I don't give you TNK or TPA, chances are by doing good conservative management, your stroke symptoms are gonna get better. And I wouldn't, even if it's like 2% risk of hemorrhage, I wouldn't risk it. But if it's, as I said, personally, aphasia, field cut, vision changes, an NIHSS of 1 in a taxi driver could be disabling. Like let's say if they have quadranopia, or you know, so I basically put a lot of weight on what the patient does, what's everyday life for them, and then what is the symptom. I wouldn't go based on just the number of NIHSS.
Mhm. So if I am right, you consider his disability regarding his job and his general condition, not
Yes,
only NIHSS.
yes. And I actually put it in front of patients. You know, sometimes it's hard for them, but I give them, I say, you know, one every, let's say if it's 1 hour, out of every 3 patients that get this medication at 3 months, one of them,
Mhm.
you know, like now you can't walk, but you can walk.
Mhm.
Versus, you know, in our hospital, like less than 1% risk of hemorrhage, half of which could be asymptomatic.
Mhm.
Like I know sometimes it's hard for them to decide, but I kind of try to put it in simple words and then have them decide. In straightforward cases, I try not to make them confused because it's just gonna be non-stop confusion and it's gonna create you know, affect the door middle time. But yeah, in those cases, I discuss it with the patient.
Uh, Dr. Nurian, I'm discussing my cases, real cases.
Yes.
I remember my first patient, which which I gave a TPA 10 years ago. He was brought from his office to our emergency room. He developed right side hemiparesis and aphasia for 2 hours.
Mhm.
He can't speak, and he didn't have any of his family or especially first rank family with him. Do you need any consent or agreement from the patient or his family for ordering the TPA?
We used to have a written consent as a requirement, but now we don't because it's a standard of care. Um, but if I don't have, especially in patients who have aphasia, if I don't have a good exact timing, like patients who are brought from nursing homes or the patients who find people like have found them outside. Like this patient was on the street, you know, people found him or her. You know, these are tricky situations. Like I would, like someone like that with aphasia and right-sided weakness, I'm like probably not safe enough to consider thrombolytics if we don't have a good observed time. I would go straight to first get CTA because I know that if it's thrombectomy case within that time range, I would just go straight to thrombectomy, not risking it with the hemorrhage and waste time. And if I have observed, but patient do not have any family, like he or she was talking to someone in clinic, and all of a sudden this happened, then we usually use you know, documentation of 2 physicians like me and emergency medicine physician that this is necessary, and we proceed with the TPA administration or TNK administration. But the written documentation in the note for us is enough, basically. No consent.
No consent. Really, in Iran is saying, because we consult with one of our legal physician, medical legal physician, they said that TPA is similar to any emergency procedure. For example, in a patient with a status, you don't ask the patient or family to give them phenytoin or any other anti-epileptic drugs. So thrombolytic is same as that.
Exactly.
I
Like
think
perfect example. Like if you give phenytoin, patients can develop like arrhythmia, which could be life-threatening, rare cases. But you don't like go over all of that. If you want to do that, you're for every basically emergency situation, you're gonna lose the time that we can help the patient. Absolutely.
I think one of our colleagues in the name of ABC, wants to unmute his or her microphone.
Sure.
Unfortunately, your sound isn't comprehensible. Dr. Norian, do you
Yes.
hear
I
our
couldn't
colleague?
understand. I couldn't understand. I
Okay.
see one question actually, Dr.
Yes, yes,
Hadej,
yes.
Dr. Jalal Hadej mentioned that sometimes we encounter with cases who had minimal symptoms like mild dysarthria for more than 4.5 hours, but his or her symptoms got worsened suddenly within the last 4.5 hours. What do you recommend in this situation, considering brain CT did not show any hypodensity? So I think the clock should start with no symptoms. If we have worsening in the last 4.5 hours, but we have initiation of symptoms earlier, uh, thrombolytics should not be considered.
Mm.
Let's say if a patient has numbness for like 5 hours and then have or even 2 hours, and then we have aphasia and right-sided weakness, and now we are, let's say, right at 4.5 hour or 5 hour. I personally would not consider thrombolytic because of the first symptom. And the challenge with patients who are not with anybody, and then they're noted that, oh, he was outside, and all of a sudden, we realize the challenge is like, we don't know, like maybe patient had like some facial droop or numbness, and then was doing, work outside their backyard or yard in front of their house, and then all of a sudden, a neighbor sees them 2 hours later with like worsening and then falling down. These are very tricky situations that I think we need to spend more time to get more information, do perfusion imaging, those types of things versus like jump and then give the thrombolytics. It's too risky.
Dr. Nurian, you spoke about the role of, for example, Google Glass.
Yes.
What do you think about the role of AI in future of treatment of a stroke? Because I have heard that there are some programs that can analyze the CT scan, all of the data, and decide about which patient is a good candidate for thrombolytic.
Absolutely.
What do you think?
It's a lot of work that's being done in any of the stroke conferences you go, these companies that present their work. Practically speaking, what we have right now is when we order CT angio and CT perfusion, depending on what company that they work with, they have some AI capacities. For example, in our center, obviously, the perfusion studies that came from papers based on Stanford, they use this cloud technology that the images are sent with any perfusion, and then the AI will decide the penumbra size, the core. So it's not manual measurement. It's not without errors. Like when I look at it, I'm like, it doesn't make sense. But what I've seen is very good, especially even helping radiologists. By the way, we don't wait for radiology. We look at the CT immediately and we act on it. But it has been used with detecting, the counting Hounsfield units on the left and right, the MCA area. You see there is possible MCA sign. It has been used in CT angio to look for possible LVO. Like when I look at the images, it automatically shows like the territory and say possible LVO. That part is AI is coming more and more in the picture. I've seen, cases that I I didn't detect it and AI helped me. And then on the other side, I've seen cases that it says LVO and then you look at it and then you kind of it helps, you know. AI says it's LVO, but then you're like, no, that doesn't make sense. It's like a stenosis or, you know, but it's good, especially for in the US. I know in Iran, the neurologists probably see more cases than a vascular neurologist here. But here, general neurologists are very, very uncomfortable with taking care of stroke patients. So if you have a CTA for a general neurologist, this AI can help them to make those decisions. Or even in some centers that they don't have, you know, any neurologists, so the ER physicians decide, the AI technology can help. Believe it or not, here there are some centers that, you know, the physician and one physician is responsible for the whole city of, you know, tens of thousands or less, 10,000 people, and then that one physician does anything from appendectomy to child delivery and giving TPA. So, you know, for those cases, I've talked to a couple of them. They help. You know, it helps. So yeah.
It seems that we have very similarities.
Yeah.
I think there is another question in chat box. What would you recommend about a patient with minor symptoms related to posterior circulation stroke, like mild imbalance with dysarthria and incidental left internal carotid 1 centimeter aneurysm with 40% basilar artery? Oh, very complicated case. Management with DAPT versus aspirin or something else. Arrived after 4.
Yeah, so this one, the easy one is the patient arrived after 4.5 hours, so we are not thrombolytic. For that 1 centimeter aneurysm, because it's a 40% stenosis, it's not severe. So I personally go with single therapy, and then maximum risk management, optimizing risk factor. But if it was like 70%, 80%, you know, then the story might have been different. You know, with ICA, you know, if it's like proximal or like it's the shape of the aneurysm, I would discuss it with you know, neurosurgery and vascular, you know, neurointerventional, depending on the pattern, the neck, and you know the other risky versus not risky. But in these cases, you know, I would be a little bit more um, on the conservative side, and then use like single therapy, because the reason the answer most of the time is not in like dual antiplatelet therapy or single therapy. It's more in the risk factor management, and you know, those are kind of underlooked. The fancy option is always like Plavix or like new medication, and patients like it, but especially like us Iranians, we like medications. Like if I go to a doctor and they give me medication, I feel better. But a lot of times, you know, managing risk factors might not look like the fancy option, but they usually help you more if you are aggressive about this. In this case, with a 1 centimeter aneurysm, if it's like 40%, I would probably do aspirin only, and you know, high dose statin.
Any question in time box? It seems that we don't have any question.
Well, I put my email at the end. Anyone who has any questions, any complicated case, if there is any way I can help with the, you know, designing of stroke center or trying to optimize that, anything I can help. That a lot of times you don't know what you can help and what you can't help. I'm sure with you know, theoretical stuff, you guys, I mean, I was in Tehran University, you know, the standard of work and learning is like more than most of the academic centers anywhere. But you know, as far as like exchange of information, what's commonly used, what people are comfortable, it's a matter of like when you see a colleague from another hospital, you always thought, hey, in your hospital, what do you do? I think it's good to have at least you know, conversations to kind of see how everybody is comfortable from their complications, from their success stories, and if there is any way we can improve the quality of care, the efficiency, and you know, even like designing you know, telestroke networks and coverage. I think even with iPhone, there is a lot that can be done. I've given TPA to patients with just iPhone. So I think there's a lot that can be done with improved communication these days. So I'm happy to help in any way I can. You know.
Thank you so much, Dr. Nourian.
My pleasure.
I am really honest that it is a great honor for us to have an Iranian physician, an Iranian neurologist, an Iranian colleague in the United States who is so much open-minded and who accept our comments and who wants to be in connect with his colleagues in Iran. It is a very great honor. Myself enjoyed so much from your lecture and your comments in about our questions. At the end of this session, I want to only remind my colleagues that next week at the same time, we have a similar session about the treatment in neurology, which is about the treatment of neuropathy. The moderator of that session will be distinguished and outstanding physician, Dr. Nafisi, and the speaker is Dr. Hadi Muhammad Khanli. And I should
I actually put it, I don't know if you guys see it, I put it on the screen so you have more information.
Thank you. And also I should thanks Dr. Yagmai, who tries so much for preparing and the regulation of this session. And also I should thank so much from IT Center of the Tehran University of Medical Science. I hope all of our Iranian in this session have a good night. And Dr. Nourian, I think, I hope you should have a good weekend.
Thank you. Yes. I also want to thank Dr. Yagmai for facilitating this and following up. Whenever I got back to her, she would follow with persistence, which was amazing, and I appreciate putting this together. I know when I was a student or resident, or you know, even now, any opportunity that I can talk to and collaborate or talk to my colleagues is very helpful in improving my practice.
Thank you.
Thank you.